Well, again, thank you all very much for having me. This is a thrill. Oops. There we go. Okay. Yes. And I really appreciate the opportunity. And I appreciate you accommodating the time difference for me. This works out perfectly. So we're going to talk about the title that I have here is left over from something else, The Economic Case for Improved Medicare for All. That covers what I plan to say. My focus will be on what's wrong with US healthcare and how economists, or some economists, have made things worse. And I'm going back to how neoclassical economists, orthodox economists in the United States think about healthcare. Some of this draws on things I heard in seminars in the 1970s with people like Richard Zeckhauser, who was, at the time that I knew him, head of the Kennedy School of Government at Harvard. From there, he went on to be a major healthcare advisor to several American presidents and one of the architects of everything that's wrong with our system. And I'm going to talk about how we should open the economic frame, the way we look at healthcare, and think about how the economy is actually endogenous to our healthcare policy, and how better healthcare policy can have good economic outcomes. Okay, first, a bit about what's wrong with US healthcare, both cost and quality, because the United States, we've managed to, for one of the world's wealthiest countries, we've managed to achieve a relatively bad healthcare system that is also very expensive. Now, this is impressive. And it's largely what's happened since the early 1970s. Back in the early 1970s, we had somewhat expensive healthcare, but we had very long life expectancy compared to the rest of the world. The United States was still a leader in controlling infectious disease and dealing with problems of chronic care. So the United States was doing very well with healthcare, a bit expensive, but everything was expensive in the United States back then compared to other countries, especially activities involving labor-intensive activities, because wages were high in the United States. So in the early 1970s, we were doing pretty well. Since then, it's gotten worse and worse. Now, here's where the United States stands today. Each diamond here represents a member state in the Organization of Economic Cooperation and Development. We have the logarithm of spending on healthcare, per capita spending on healthcare. So you can see the United States, we're spending almost 50% more than any other country. Yet we have life expectancy that is below the average for the OECD. I'm sorry, I can't point which country here, which diamond here is Turkey, but you can see that the United States has life expectancy comparable with relatively poor countries that are spending much, much less on healthcare. We have life expectancy that's almost the same as Chile, which is down here, which is a wonderful country. I don't mean to criticize Chile at all. But they achieved the same life expectancy while spending $7,000 less per person. We're spending $10,000 per person to have life expectancy, male and female, pooled together of 78 years. They have life expectancy of 78 years while spending $3,000 per person. What's more, we've been losing ground in quality. As I said, we used to be pretty good in healthcare. In fact, if you extended this graph back to 1971, I mean, I stole this from somebody else, the British Medical Journal. But if you go back to 1971, we had longer life expectancy in the United States than most countries in the OECD again. But since by mid-1990s, we had fallen to average, and now we are well below average. And you can track this. This this is a great graph. I had one of my own that was like only had 7 countries in it. But these guys put together all the different countries every year, and the graph is better than mine. As I said, back in 1970, we were spending a little more than everybody else, but we had good health care, good outcomes. Over time, our spending has been increasing faster than everybody else, but our gains in life expectancy have been less. So now, compared to these affluent countries in the OECD, the United States, has inferior life expectancy while spending more. So what's been happening is we've been spending more and more and more for the same gains in life expectancy. I've estimated that every additional year of life expectancy has cost the United States about 5 times as much in per capita spending as the average for the OECD. That is a measure of how inefficient our healthcare system is. Given how much it costs us to gain 1 more year of life expectancy, we would have to spend $9,000 more per person, which would mean we would have to almost double our life expectancy. Yeah. We're already spending 17% of our GDP on healthcare, which is, as I said, about double the average for the OECD. We would have to be spending 30% of our GDP on healthcare, which is like, to reach the average. That's only the average. So what we've been doing since 1970 has been failing. Especially if you look, between 70 and 80, we did okay. It's really since 1980. Some of you who know American political history will know that 1980 was the election of Ronald Reagan to president of the United States. I'm not blaming Reagan in particular, but I will blame Richard Zeckhauser, my old teacher, because Zeckhauser was Reagan's chief advisor on healthcare. Okay. Now, why is our healthcare failing so badly? Yeah. Well, it's pretty clear that a major reason American healthcare is failing is because so many Americans can't afford to access healthcare. They can't afford to go to a doctor. Every diamond here represents a county in the United States. We have about 3,000 counties. They vary in size from Los Angeles, which has close to 20 million people, to some little teeny places in South Dakota that have a few dozen people. But we have about 3,000 of these counties. And shown here is a result of a survey conducted by the University of Wisconsin and the Robert Wood Johnson Foundation, asking, anytime during the past year were you unable to go to the doctor because of cost? And as you see, and also for every county, the age-adjusted mortality, taking account that some counties have old people, and so they have more deaths. Some counties are younger and invincibles, and so they don't die. Taking that account of age, counties where more people could not access the healthcare system had higher mortality. Why should this be a surprise? If you look back to here, or here, or here, you see that where you spend more money, you generally get longer life expectancy. Here we're spending more money, everybody's spending more money on healthcare, people are living longer. Here, where people can't go to a doctor, they die. Going to a doctor helps you live longer. Being able to access healthcare means that you can afford to buy the drugs prescribed by the doctor. In a seminar in 1980, before he went back to Washington, Zeckhauser said that doctors do nothing to help people live longer. Seeing a doctor is entirely a consumption activity like skiing All the gains in life expectancy since 1990, he concluded, were due to clean water and public health. Nothing to do with anything that doctors do. Now, he went on to tell some jokes about this, but that's been the approach that economists have had in regard to US healthcare. Healthcare expenditure, healthcare spending is consumption. I spend money on my dog. My wife spends money on her garden. You might choose to spend money going to the doctor. It's all the same. It's all consumption. We don't subsidize my dog. We don't subsidize my wife's garden. Why on earth should we be subsidizing you going to the doctor? The result of this is clear in this graph. Places where people can't afford to go to the doctor, they actually do end up dying, because going to a doctor would have helped, but they could not afford it because of the way we've designed our healthcare system, treating healthcare in the United States as a consumption good. Now, when economists, many economists, I mean, Martin Feldstein, former head of the Council of Economic Advisors, said this. I've heard this from many people. Why is healthcare so expensive? It's because people use too much of it, because, to quote Feldstein, who said this many times in print and in lectures, healthcare is free on the margin. Now, he's saying this in, when I've heard it, in papers published in the 70s, and he said it when I heard it in 1979. So, obviously he would say something a little different today. But the problem, as he and other economists identified it in the late 1970s, was that we're spending a lot on healthcare, more than other countries, because we use too much of it, because we have too much insurance. Well, in fact, Americans don't use a lot of healthcare. The average American goes to sees a doctor about 4 times a year. The average for the OECD is over 6 times. You know who has the most? Who sees the doctor the most? The Japanese. They see a doctor 12 times a year per capita. And you know what? The Japanese have the longest life expectancy in the OECD. I mean, there may be other things having to do with this, but Fukushima and mercury in fish notwithstanding, the Japanese live longer than everybody else, and they see the doctors the most. We don't use too much healthcare in this country. In the United States, our average stay in a hospital is less than the average for the OECD. The Germans spend a lot of time in hospitals, 8.9 days for every acute care episode. Is that too much? I don't know, but the US we're below the average anyway. A third of Americans report that they could not do something in healthcare. They could not access some healthcare. They could not fill a prescription. A quarter of Americans report that they did not fill a prescription last year. This is a prescribed drug recommended by a doctor, and they did not fill it. They walked out of the doctor's office, they looked at the prescription paper, they thought about how much it was going to cost, and they dropped it in the wastebasket and hoped that they would survive. Well, you know what? Sometimes they don't. We do worse. More Americans have multiple chronic conditions. Why? Well, maybe part of it is that they didn't treat these conditions earlier because they weren't able to afford to go to the doctor, and they didn't use the drugs that were recommended. Almost 15% of Americans report that some friend or family member passed away in the last 5 years because they were not treated for a medical condition because they couldn't afford it to pay for it. Surprise, surprise, this happens more to non-whites. It happens more to poor people. It happens less to rich people. On all these graphs, by the way, I'm sorry, I did not include Turkey because I'm focused on countries of a affluence level comparable to the United States. So, comparing likes and likes more or less. And what's been happening in the United States the last 40 years? I'm sorry, this is the title here, 1975 to 95. These are people who entered the Social Security system. They hit age 65 between 1975 and 1995. And it's tracked them over the next 25 years. 15 years, sorry. The richest people, those from the cohort of 75, who turned 65 in 1975, those who were born in 1910, the rich lived about 4 years longer. Those who were born in 1930, the rich lived 5 years longer. So the rich gained a year, which is okay. That's pretty good. It's about the average. The richest Americans gained in life expectancy about the average for the OECD. But the poorest Americans, they actually lost ground, especially women. The poorest 40% of American women gained, actually had shorter life expectancy for the cohort of 1930 compared to the cohort of 1910. The poorest American. Now, the first time I presented this graph was at a group in Oregon, out west. And I said that this is amazing to me that, how could this have happened? With all the medical technology, all the improvements, how could women not be living longer? Actually be living shorter. Afterwards, a woman came up to me. She worked in a food bank for poor people who could not afford, did not have did not have financial support from the government, could not afford to buy food. And she said that when mothers would show up to get food, and if they didn't have enough, they would make sure that children ate. There's a scene in Zola that's like this, by the way. But they would make sure that children ate, and mom would go hungry. Which, of course, what mother is going to eat while her children? And what mother, if you have enough money for only antibiotics for one person in the family, you're going to give it to your child. You're not going to take it yourself. I mean, so what's happening is these poor women are the canaries in the coal mine, as they say, for American healthcare. American society is collapsing because we're not taking care of poor people and working people. The giant shift in income up the ladder to rich people is hitting these people particularly hard. The poor men, they're still able to get by, but poor women are doing worse. Now, these problems are not accidents. They're exactly the response to what economists, neoclassical economists, they haven't been listening to me, or my friends, but what the neoclassical economists think about healthcare. And here's, the focus of economists is on moral hazard. The problem is people have insurance, so they don't pay on the margin for their healthcare, so they abuse the healthcare system. They use too much. The solution is matching prices with costs through copays and deductibles, and then competition among insurance providers so that among insurance companies and among healthcare providers, so that they will all be driven to compete effectively by controlling costs. And if it means that we use less healthcare, that's no problem because we're using too much anyway, and there's no benefit to that healthcare. This is the program that people like Zeckhauser and Feldstein were pushing in the 1970s and 80s. And a lot of it has been implemented in the way the United States deals with healthcare. The results have been a complete failure. Insurance company competition has not led to efficiency. Private insurance has failed to control the prices charged by providers. Utilization has lowered spending in the short run, maybe, but utilization review by insurance companies has led to inflated administrative costs and raised costs in the long run. And all of it has undermined the efficiency of the US economy. Okay, I'm going to go back to my teacher, Kenneth Arrow. He founded health economics. Rarely in the profession. I guess there are some other cases, like Keynes's general theory kind of created macroeconomics. Kenneth Arrow, his one article in the American Economics Review in 1963, Uncertainty in the Welfare Economics of Medical Care, was like the first time that economists had seriously looked at healthcare. which is kind of interesting because healthcare, even back then was a significant part of the economy. But in any case, this was where it all began, which is a damn shame because as Arrow was saying in the 70s and 80s, it looks like nobody actually read his paper. But here's what he said. First of all, he starts with the kind of, a lot of this is obvious, but, isn't that the best academic work that puts words on the things that are obvious? Common sense represented, in analytical economics. Healthcare spending is highly price inelastic. People just look for good healthcare, and they'll spend whatever they can afford to stay alive. People buy insurance. Medical costs are highly variable. 70% of healthcare spending in the United States is associated with 10% of the population. That should not be a surprise. A third of the population spends nothing on healthcare. They're healthy. Nothing goes wrong. I found out yesterday that I've forgotten to make an appointment to see my doctor. I'm supposed to have a checkup every 6 months, and the doctor's office called. I went looking through my calendar. Nope, never made an appointment, just forgot all about it. No problem. I've been doing pretty well. Who spends money on healthcare? The person over there who got cancer. These days, the person over that way who got COVID, although COVID doesn't actually cost that much. Usually you get over it or you die. But there are these long haulers who COVID doesn't go away. Those people are going to be very, very expensive. You get hit by a car, oh, you get a lot of expenses. It's very variable, and you don't know what's going to happen. You don't know if you're going to be hit by a car tomorrow. You don't know if you're going to get cancer. You don't know. So standard neoclassical economics would be given diminishing marginal utility. This is first year microeconomics in graduate school. Show the economic benefits of insurance. People want insurance because of the highly variable cost of the future. You don't know. So you'll give up something now to make sure that nothing terrible happens. This is going to lead to lots of problems. Insurance is going to lead to lots of problems. You're going to have the problem of third-party payment because it's the insurance company that's paying for things. You're going to have the problem of adverse selection. Insurance companies look at the variability in healthcare spending to try to figure out how can we market our policies to the healthy people and screen out the unhealthy. And it does mean healthcare is going to be free on the margin because your insurance covers it. Patients lack information about treatment. You don't know. You go to the doctor. You have some problem. You don't know what the problem is. You feel a lump. You don't know if it's cancer or nothing. And if it's cancer, you don't know whether it's going to be malignant or benign. So we go to doctors for these things. Now, doctors often use expensive big machines. So you're going to have economies of scale and monopoly among providers. Worse, you're going to get monopolies because you don't know which doctors are good. So you want to go to the right doctors. And how do you know who's the right doctor? Well, in Massachusetts, you go to the doctors at Harvard Medical School. So Massachusetts General Hospital, the oldest hospital in the United States, founded by Harvard Medical School, Massachusetts General charges prices 4 to 6 times as much as the average hospital in Massachusetts. 4 to 6 times as much. And that's from a report by the Massachusetts Attorney General 10 years ago. It's probably worse now. So these brand name monopolies must have hospitals really hold the whip hand in setting prices in American healthcare. What's limited their abuse? Professionalism. Doctors are not supposed to just operate on their own, advantage. Hospitals are supposed to be nice places. They're supposed to care about people. That's the professional ethos. Well, guess what? If you tell them, well, just go out and make money, they're going to change their behavior. They're going to jack up their prices. They're going to maybe abuse the system by conducting extra tests. I'll give you an example of this. Someone I knew was head of the public hospital in Cambridge, Massachusetts. Sorry, not the head of the hospital. He's head of the emergency room. He said that if somebody got hit by a car in front of his hospital and was taken into the emergency room, they would do an MRI and maybe ship the person, because that's what the person wanted, to Mass General. After stabilize the person, then okay, go to Mass General across the river. Mass General would then redo the MRI. This is just abuse. They're using the same machines. It's probably being read by the same person down in Bangalore, India. That's where a lot of this stuff is done now. But Mass General would redo the MRI unnecessarily and then charge 4 times as much for the same MRI done with the same machine and read by the same physician. Well, why was Mass General able to get away with that? Because they're Mass General, they're Harvard. Why do they do it? Because they're just out for money now. If they were behaving by the Hippocratic Oath, if they were acting as professionals, as Arrow said was so important, then they wouldn't do that. But we've taught hospitals, we've treated hospitals and doctors like they're supposed to be money machines. Okay, economists have been very selective. As I said, Arrow's article is one of the 10 most cited articles in economics in the United States. At one point, I looked at the Google searches, Google sites. It's in the millions and millions. But economists, I often wonder how many actually read the article before they cite it. They focus on moral hazard, which is very secondary in articles, and overuse of healthcare. Arrow doesn't talk about that at all. Well, except to say that professionalism will limit it. They reject insurance because consumers should be paying on the margin. The problem is moral hazard. You have insurance or you overuse the system. And they supplement that by saying doctors are useless. They talk a lot about the Samaritan's dilemma, the danger of government programs undermining free markets because they'll provide free healthcare to people. And sympathy and charity will lead people to pay for other people's healthcare. So we got to stop that. That's going to lead to abuse. They ignore adverse selection, rents, and increasing returns. Okay, if moral hazard is the solution, the problem, the solution is consumer cost sharing. So healthcare costs, healthcare consumers, that's what they always talk about, healthcare consumers pay on the margin for their consumption. Co-pays and deductibles. The average employer-provided health plan in the United States now has a deductible of over $2,000. So your first $2,000 you pay out of pocket. Most people, that is, the median person spends less than $2,000 in the course of a year. Certainly the median person under 65 spends less than $2,000. So the median healthcare consumer in the United States has no insurance, or they have catastrophic insurance. You could say, well, the coverage will pay for things if they have a disaster. There's your incentive not to go to the doctor. And then they rely on competing for-profit insurers to police utilization. Make sure you don't abuse the system because we won't pay for it unless we approve it in advance. And provider prices. So we'll go to Mass General and tell them not to charge so much. Jumping ahead, spoiler alert, it doesn't work. Okay, healthcare replace insurance with markets, insurance market competition, empower insurers over doctors, payment reform so that doctors will start acting like for-profit companies. Okay. Financial incentives. It's all about financial incentives these days. All the talk about payment reform, both under Obama and under Reagan. Payment reform was about undermining professionalism. So doctors will not just provide care, but they'll think about how much it's going to cost. Yeah. But if consumers don't know and can't know what they need, who do you go to? Your insurance company? They're going to make money if you don't use healthcare. Go to the doctor. Well, the doctor is being given a financial incentive not to provide care also. The insurance company is going to try to restrict everything you do, and providers, where are you going to go? You're not sure what's wrong with you. You want to go to the best doctor. So that's the monopoly. No system of payment reform can get around these problems. Okay. My father was in business. He was ran a coffee company in New York City. Was fairly successful. Became very, very successful when my brother took it over. My father was good. My brother was better. But how did my father and my brother make money? This is where capitalism works. I mean, spoiler alert, I consider myself a left socialist, but I recognize there's some good things about capitalism. My father's company, my brother's company, was an example of the good thing about capitalism. My father would make more money when he sold more coffee. How did he sell more coffee? By getting better coffee. By providing it at a better price. By managing the operation of his company to be really efficient so that they could sell the coffee, quality coffee, at a better price. Insurers don't work that way. Private health insurers profit when you don't use their product. How do they maximize the number of people who won't be using healthcare? The 70-10 rule. 70% of the costs go to 10% of the people. Find the 10% and drive them out. That's called lemon dropping. Cherry picking. Identify the people who are going to be healthy. At this point, if we were in person, I would point to some young person and say, you're the one they want. Me, they don't want. Look at the gray here. They don't want somebody like me. They want somebody like that young person over there who's probably not even going to go to the doctor all year. And if you're a for-profit private insurance company and you don't cheat, you don't lemon drop and cherry pick, you're going to go bankrupt. You provide good quality care, like my father provided good quality coffee, you'll attract the sick people, the people who are going to need care, and your coverage will become more expensive. Your premiums will go up, and before you know it, the healthy people are going to opt out, and you're going to have to raise your rates even more, driving the healthy people out. How do you handle this problem? Well, one thing you do is you make it harder to apply for coverage. Honestly, nobody has the administrative cost of the American healthcare system. And by the way, the difference is not between the United States public sector, which is relatively efficient. About 2% of costs, 3% of spending in US public sector healthcare is administrative overhead by the insurers, which is about the same as for the average for the OECD. All the difference in the US, where we spend 10% of our healthcare dollar, all the difference is in the private sector. Because the US private sector, and the US private sector is no less efficient than the private sector in the Netherlands or Germany. The US spends more on administration healthcare because we have a much, much bigger private sector. And it's the private sector that's inefficient. Actually, maybe I dropped it, but I had a picture of the forms I had to fill out for some physical therapy I needed a few years ago for, I forget what, my foot. I had to sign my name 11 times on these forms. I covered the table with the forms. It was bizarre. Whatever happened to electronic medical records? But, why? Yeah. I mean, if you make it difficult enough for people to file claims, they're going to give up filing claims. That's incentives. Okay, why is healthcare actually expensive? Part of it is the administration, but the biggest part is private insurance companies can't control prices. This is what's happened in California since 2000 or since 95. Private health insurance companies are paying much, much more in hospitals than are public companies, because the private health insurance companies are all too small to bargain effectively with companies like Mass General. About 10 years ago, James Roosevelt, the grandson of Franklin Roosevelt, is head of a nonprofit health insurance company in Massachusetts. He went to Mass General and he told them, we're not accepting your inflated prices. You need to bring them down. Mass General told him to take a walk. Within 48 hours of the public announcement that they weren't going to deal with Mass General, he surrendered because so many of his subscribers told him, we're not going to use your health insurance if we can't go to Mass General. Monopoly power. Insurers don't police providers because they're selling a product and they fear alienating their market if they don't have brand name must-have providers. Here's drugs. Oh God, what a scam. This is absolute. People die because they can't get insulin in the United States. I think that's the next one. Yeah, here's insulin. Insulin prices in the United States. Do you know where insulin comes from? Who developed it? These two chemists in the University of Toronto in the 1920s, they developed artificial insulin. It saves thousands of people every year. And they gave it to the world for free. Like Jonas Salk donated the polio vaccine to the world for free. But in the United States, and that's the way it works in most of the world, but in the United States, a few companies have gained control, not of the patent, but of the production process. And they've driven up prices and people die because they can't get the insulin. When insurance companies do try to do something about it, they establish restrictive networks. They say you can't go to a doctor outside of the network unless you get special approval. That just disrupts care. It makes everything worse, and it doesn't for patients, and it doesn't actually, apparently it doesn't lead to control over prices. Oh, here are my forms. Forms for my physical therapy. Oh, God. Oh, that's something from David Kotz, my colleague. Okay, opening the economic frame, talking about the economy as endogenous to a healthcare system. I mean, this should be obvious. Healthcare is not a final product. When I go skiing, that's the final product. When I go to a doctor or I take a drug, it's not for the pleasure of going to the doctor and taking the drug, although I do like my doctor. But it's to get healthy. Healthcare is an intermediate product. So designing a good healthcare system is like designing a good factory so that you can be more productive. Productivity depends on health. And also productivity depends on the transactions costs, the cost of doing business. This goes back to that great conservative economist, Ronald Coase, and Douglas North. Douglas North was a communist in his youth, by the way, but he was not later on. Transactions costs depend on social trust. And if you don't have trust, you can't do business effectively. You have to spend more on policing. And trust is undermined by the way we're dealing with healthcare. Healthcare is an economic asset. Healthy people are more productive. Healthy children learn better. Healthy workers are more productive. They don't miss as many days of work. Among member states in the OECD, a 1 standard deviation reduction in preventable years of lives lost, which is basically going from the United States down to Germany, associated with a 10% increase in labor productivity. Mental illness is higher in countries with less equality. Our healthcare system in the United States is producing more inequality. Educational scores are higher in more equal countries. Again, our healthcare system is making children sicker so that they can't learn as well. They miss more days of school than do children in Japan or Germany or Finland. And here's data on healthier workers and more efficient. This is GDP per hour versus preventable years of life lost. Now, obviously, there's more to it than this in explaining inequality, productivity in different countries. But part of it is the quality of the healthcare system. And the United States, we're all the way out here and out here in preventable years of lives lost, and that is contributing to our lower productivity. Not even talking about the funerals. Roughly speaking, 250,000 extra dead Americans every year because people can't afford to go to the doctor. I think that's a kind of conservative number. I'm working on a project now with some other people on COVID mortality. About 100,000 extra American deaths are associated with the lack of health insurance among Americans. 100,000. On a normal year without COVID, 250,000 extra deaths. A lot of these are older people, but many of them are of working age or younger, and we are wasting the human capital that's been invested in these people. Life expectancy is longer in countries with more equality. Social solidarity. It's like in the United States these days, well, maybe with the new administration, there's a little talk about it, but social solidarity, people feeling like they're in it together and they're going to work together. This has always been, by the way, historically, has always been a great American asset. Americans trust each other more than do people in most other countries, or at least they did until recently. Americans have more confidence in their government. Alexis de Tocqueville in Democracy in America in the 1830s talked about this. And of course, it's always applied more to white Americans than non-white Americans. But, this social solidarity has always been a great economic advantage for the United States. And we have undermined it with this focus on profit making and market incentives. Treat people better, take care of everybody, you have less conflict. There's more conflict in the United States these days than there used to be. The UK, God, I don't know what's going on there. Health and social problems worse in more unequal countries. Worse in more unequal states. Let's see, can I find Massachusetts quickly in here? Here's New Hampshire next door. There's Maine. There's where I grew up, New York. I don't know what they're doing. It's a bit of an outlier. Somewhere there's Massachusetts. Yeah. See, we're very virtuous in Massachusetts. Even though we have a lot of inequality, people still take care of each other. And we also, by the way, Massachusetts, Connecticut, New York, states with high inequality are also states where the government has been very active in providing health care and access to health insurance. These are some of the best states in terms of the implementation of the Affordable Care Act. So the bottom line, don't listen to neoclassical economists. Buy my textbook, my microeconomics textbook. Come to UMass, send your students to UMass. We always do very well, as some of you know, with our Turkish graduate students. But don't listen to neoclassical economists about healthcare or about anything else. The narrow focus on market incentives undermines healthcare. and leads to economic inequality, undermines efficiency, undermines social solidarity. Yeah. So thank you very much. I really appreciate the chance to present this to all of you, and thank you for the